Thanks very much. The talk has evolved since what you've just heard, and I'm going to talk about something completely different, or at least quite a bit different, and that is progress in evidence-based medicine, so looking at guidelines from the lens of evidence-based medicine. And before I start, just to decide on how I'm going to pace some of this talk, how many people in this room have used GRADE as part of a team doing a systematic review or guideline? How many have? Okay, almost everybody. All right, so my section on GRADE will go very quickly. So, conflicts of interest. I'm co-chair of the GRADE working group. I'm a member of Making GRADE the Irresistible Choice, or the MAGIC board. I'm a member of the steering group of Bmj Recommendations, and I'm a consultant to Up to Date. So what I'm going to do in this talk, I'm going to talk very briefly about EBM at the start and its evolution and how it's ended up with a major focus on guidelines. You are all familiar, virtually all of you are familiar with GRADE in terms of using it. Just mention it as the cutting edge of EBM, and then a relatively new initiative, Bmj Rapid Recommendations, which I see as the forefront or cutting edge of EBM guidelines. And I'm going to finish off with what you who have used GRADE, give you something to think about in some of the challenges of using GRADE. So this is the first paper in which the term EBM appeared in the medical literature in the ACP Journal Club in 1991. And to give you an idea of just how long ago that was, this is what I looked like at the time that paper was published. So the initial focus on EBM when we got started was teaching clinicians to use the medical literature. There was a big emphasis on teaching clinicians critical appraisal, how to look at the results, and then application. During the next 10 years, one of the things that happened is I spent 7 years as director of an internal medicine residency program, which was something of a laboratory effort to see what you could do with EBM in residency training. And at the end of 10 years, it was clear to a number of us that most clinicians will not have the skills when they finish their training to do a sophisticated critical appraisal, and nobody will have the time to do a sophisticated critical appraisal on all the questions that they were addressing as clinicians. The results, teaching clinicians to understand the results and apply them was still important, but the critical appraisal was not going to happen at the level of the individual clinician. And that means that we have to change our focus. So we still have, on this slide, it shows three pictures. The first being the hierarchy of evidence. So we know that some evidence is more trustworthy than others. We had simple hierarchies in the past. GRADE represents a more sophisticated hierarchy. And then there is processing, starting from individual studies, moving to systematic review and guidelines. And on the right side of the slide is what we now suggest for clinicians using the medical literature. Find a summary or guideline first. That's where we now suggest clinicians taking EBM approaches start, and then only if that's not available, go to less processed evidence. So, having decided now that clinicians' critical appraisal is not going to be the primary source of how they gather and use the evidence, something different. Andy Oxman got the idea of GRADE started, and this is from the first publication in the BMJ in 2004, where the medical artist, I think, captured some of the challenges of doing guidelines, which sometimes does feel like walking a tightrope. Subsequently, in 2008, the BMJ published a 6-part series on GRADE, which explained it in more detail for users of guidelines. And we've been pretty happy at the uptake. Over 100 organizations worldwide using GRADE, prominent ones, the Cochrane collaboration, the textbooks. Oh, another question. Who in this audience takes care of patients? Hands up. Okay, minority still. Of those who take care of patients, anybody use UpToDate? Who uses UpToDate? So lots of those who take care of patients. So from organizations like Cochrane, from electronic textbooks like UpToDate for Clinicians or Dynamed, EBM's or Grade's approach has been massive uptake. So how does it work? Most of you have used it, so you're familiar with this. Randomized trials starting as high-quality evidence, but 5 reasons for rating down: risk of bias, inconsistency, indirectness, imprecision, and publication bias. Observational studies starting as low quality, but possibly being rated up, most often for large or very large effects. Grade has an approach of binary for recommendations, which are strong or weak, although some organizations don't like to give weak recommendations. They prefer to give conditional or contingent recommendations, alternative words for the same thing. How do you decide whether a recommendation should be strong or weak? Initially, Grade identified the magnitude of the benefits and harms, the quality of the evidence, and a number of aspects of values and preferences. What were typical values and preferences? What is the variability in value and preferences in the population for whom the guidelines are intended? And how certain are you regarding the values and preferences? What's the evidence about people's values and preferences? More recently, Grade has identified additional criteria that guideline panels often should consider, or they should at least consider considering. Those are costs, the feasibility of the interventions they're looking at, its acceptability to the population that's intended, and issues of equity. And in adding these additional criteria, part of the thinking led to what are now evidence to decision frameworks. And what you see in this slide is that the evidence to decision frameworks include a presentation of the relevant evidence, and then the panel is asked to make ratings of whether if they feel, for instance, the benefits are clearly large or small or absent, similar with harms, similar also issues of acceptability and feasibility. And you see when there's acceptability or feasibility, there's usually a lot less evidence available and additional considerations may become prominent. You've heard in the first talk that evidence to decision frameworks may not always be to everyone's liking. It was described, I believe, as an excessively mechanical approach. Some, on the other hand, many panels have been very positively impressed by using the evidence to decision frameworks in this particular way. It's still early days, and it'll be interesting to see how they develop. So, weak, conditional, or discretionary recommendations. We remain very fond of the approach because of its clear implications. A way of thinking of strong or weak recommendations is to look at the variability in patient preference. Strong recommendations, everyone or almost everyone who was fully informed would make the same choice. Weak recommendation, the choice varies appreciably. UpToDate has over 10,000 graded recommendations, of which 2/3 are weak recommendations. The implications for interaction with the patient are particularly important. A strong recommendation, physicians, clinicians in general, are always time constrained. A strong recommendation would suggest that perhaps one doesn't have to go through a detailed shared decision making, because if the guideline panel has got it right, everyone or almost everyone would make the same choice. A weak recommendation means that it's value and preference sensitive, and that means that we need a shared decision-making exercise to ensure that the choice is right for the patient. Shared decision-making is challenging. It's still an area of active investigation, and it needs a lot more work in terms of developing decision aids that are optimal, perhaps encounter decision aids that are designed for use with the patient and clinician in the course of their interaction may become more prominent. A strong recommendation where everyone, if the panel has got it right, everyone or almost everyone is going to make the same choice, may not need a decision aid. Quality of care criteria is restricted to strong recommendations. So, we think we've got a good idea now how to make trustworthy recommendations, but can we create them quickly in response to practice-changing evidence and disseminate them effectively? This is an initiative, Bmj Rapid Recommendations, a partnership between the BMJ and the MAGIC Research Group, which is now implementing these recommendations with a target of 90 days from practice-changing evidence, hopefully a model that will be taken up quickly by others because we need to get recommendations out quickly when we have practice-changing evidence. This is the format of the presentation that the BMJ has come up with for a recommendation. Here was an interesting one where for the older patients, it was a strong recommendation in favor of a less invasive way of fixing your aortic valve. It went down to as you got younger and younger because the new, less invasive valve, it's uncertain of its longevity, how it will last. The younger you are, the more likely you would opt for a surgical procedure rather than the less invasive one. Finally, I would like to introduce you to a challenge or insight in applying grade. At the beginning, we actually, in retrospect, were not too sure what we were rating when we rated the quality of the evidence. And some of us thought we were rating our confidence or certainty in the point estimate. But a member of the grade working group, Monica Holtkrantz, challenged this, and this resulted in this paper. And we now, some of us have concluded she was very right. And what we are rating is, in fact, our certainty in the evidence in terms of being on one side of a threshold or in a particular range. And what this emphasizes is it's not necessarily straightforward as to what in any individual situation in which we're rating our quality. So one could, in the slide that I've showed you, considering precision, if we're rating our certainty that there's a non-zero effect, this particular result, doesn't have any precision problems. If we are rating our certainty that that there's an important effect, as represented by the dotted or the line, the broken line, then the confidence interval overlaps that threshold, and we would be less confident. And it is often worthwhile thinking exactly what are we rating our certainty in when we apply grade. And here you can see it's different if we're rating our certainty in an effect at all, or whether we're rating our certainty in whether there is an important effect. I've got a minute left, so I think I will just summarize. Evidence-based medicine recognizes that clinicians are seldom able to conduct their own critical appraisal. They often, very often in one way or another, seek expert guidance on the best course of action. Acknowledging or recognizing that puts trustworthy evidence-based guidelines at the center of evidence-based medicine. We believe that grade is at the forefront of the EBM methods and guidance for guidelines. Quality grade provides quality of evidence and strength of recommendations, which are interpreted in terms of the one very important interpretation is the necessity for full shared decision-making. And finally, one of the recent insights for grade when you're using it in your guideline panels. Worth being very careful to define what exactly we are rating, in what are we exactly rating our quality. Thanks very much.
Thank you so much, Gordon, especially for keeping the time, but also for introducing us to the concept of grade. And this time, questions are already submitted by you, so I would like to highlight the two that have been asked by the audience, and I would like to start with the second one. Are guidelines developed using grade now the gold standard, and should we trust them more?
Yes.
Quick answer. But do you have any data on how panels apply grade? I remember at the last Evidence Summit, I think it was Philip Dahm saying in the US, there was a bunch of organizations saying we apply grade, but when he had a closer look into it, it was part of grade or was according to grade or something like half grade.
Yes. Well, this reminds me of evidence-based medicine.
Yeah, sure.
And the various times where people contend they're using evidence-based approaches, and one might seriously question they're not. Any innovation will be subject to appropriate and conscientious use, understanding it, and inappropriate and not so thoughtful use. Inevitable. And grade has considered its role in this, and we have decided that one thing we do not want to be is the grade police. So we put our guidance out, and it is just guidance, and it's up to people who use it. Clearly, sometimes it will be used better, and sometimes not so well.
So, some more questions that appear on the screen. One is, does grade in any way reduce the role of a committee or a group discussion and contextual input?
No, absolutely not. When it's working properly, the panel has input into how one rates the quality of the evidence. Often there's a systematic review team, but if it's working properly, that systematic review team works in terms of defining the questions and in terms of the ultimate decisions and quality of the evidence with the panel. And as already been pointed out, as has been pointed out, there's often considerable uncertainty about the evidence, if not for the basic efficacy, certainly uncertainty around values and preferences, and all that is involved, as has been pointed out. There are inevitably challenges which grade, we believe, facilitates, but the judgment of the panel is on every aspect is crucial.
And another question is, can you comment on the concept of just inform the patients, that what you said in context with a strong recommendation? The question is, in limited time, what do you think should be included in that just information and exchange?
What should be included in that information exchange? And this has to do with exactly how one defines shared decision making. So the physician in that exchange needs to briefly explain why the physician is making, or the clinician is making, a particular suggestion, what is involved in using the particular treatment. If it's a drug, what benefits are we expecting, what side effects might the patient experience, and judging the patient's reaction to what is said and making sure that the patient gets a chance to express their feelings about using whatever treatment is being recommended.
Thank you. And one last question that is very specific. Why was the Grade Working Group webpage transferred to Facebook? I don't know if you can answer to that one. It seems to me that the overview of the grade papers and the minimum criteria for rightfully claiming to use grade got lost in transition.
The short answer is I have no idea about I'm not in charge of the web page. I'm an old technophobic guy, who would have terrible problems even navigating as it is. Not sure why the minimal criteria have got lost in translation.
I see you have a lot of more questions. Maybe you could address Gordon after the plenary, because I think we should continue. Thank you so much for the great input.